Okay, let's get started. Today's study tip says, use more than one textbook. Comparison reading will give perspective and will help you catch errors. And I know you're thinking, you already spent tons of money on our textbook, why would you want another one? But as you know, I have to get new books every 2 years because the publisher updates them with new editions. If you found an older edition, maybe 10 years old, from a different author, it would be 20 bucks probably, maybe even cheaper. Shoot, people are probably giving them away for free, okay? Because they can't really sell them for any value. Nobody uses them. But you could probably learn a lot from reading another author, and like I do, I take the book and then I teach it in a different way. They teach it in a different way in their book. Um, and then you would have another resource for yourself. Okay, so think about that one, finding an old physiology textbook. Okay, chapter 16, respiratory system, part 1. So as you see, we are going out of order in the book. I had urinary first and then respiratory because I think that since acid-base balance comes next, I think that the flow from urinary to respiratory to acid-base works better than the way the textbook does it. So, no, I'm not going to write a textbook, but if I did, I would switch them, definitely. Okay, the terminology for this chapter you need to know is respiration, and that is the obtaining of oxygen and elimination of carbon dioxide. There is external respiration, which is what you think of when we're breathing. It's the exchange of gases between the alveolus and the blood. And then internal respiration, which is the exchange of gases between the tissues and the blood. Okay, so usually I think you think of respiration as breathing, right? Well, guess what? There's a different kind of respiration deep inside the tissues. It is technically the obtaining of oxygen and eliminating of CO2. Ventilation is what you think of when a patient needs to be ventilated. That's actually moving the air in and out for them. So you put a mask on and you hook them up to a ventilator, right? That's just moving the air in and out. It's not actually respiration because the oxygen is not moving when you just go in and out of the lungs, okay? So the anatomy of the alveolus, do you remember this? So yes, yes. Here is the alveolus, the very end of the respiratory tree. Remember, has these, looks like a cluster of grapes at the end. That's what it reminds me of. And the big cell here, the pink cell, there's one. There's another one. Here's the nucleus. These are the type 1 alveolar cells. They're very thin. Perfect, because the capillary also close by, very thin for the cells that line the capillary, because oxygen has to move from the alveolus to the capillary, right? And we don't want a lot of space between there. It makes it too far of a distance to travel. I want you also to see here that the type 2 alveolar cells, and they make the surfactant. So can you see this blue line all the way around the inside of the alveolus? That blue line is surfactant. We'll talk about that in a second. That is also seen here. Where else did I saw it? I guess just along the edge here of the cells. This one here is a macrophage. This is one, excuse me, that stays in the tissues. And this makes total sense because when you inhale, you get all kinds of junk coming in, right? So we have a lot of macrophages, other white blood cells hanging out in our lungs to attack, eat, phagocytose, any foreign things that we breathe in. So as you can imagine, we bring a lot of things in. Here's the white blood cell nearby to keep protection. So the alveoli have gas exchange. There are the type 1 cells. They're flat, single layer. Type 2 cells secrete the surfactant. Now surfactant is a thin fluid composed of lipids, and its purpose is to decrease the alveolar surface tension. So if you can imagine a balloon, brand new balloon that you get, and you try to blow it up, it's super hard, right, to blow. If you push, and you give it to a little kid, you know, a 6-year-old, they can't usually blow open a brand new balloon. I remember my kids having this trouble, and so I would blow it once to kind of get it going, and then, you know, it becomes larger and inflated, and then I would let them have the balloon and practice blowing, right? So opening these little teeny microscopic, balloons in our alveoli is very hard to do because it's so small that the sides are actually attracted to each other, and they have what we call surface tension. With the lipids, it makes it kind of slippery. So it's like having an oil there, so that the two sides are, not two sides, but so that the sides of a balloon, there's of course many sides to a balloon, right? It is a sphere, has the ability to open more easily. And so babies are born with surfactant already in their lungs, but premature babies are not. And so it's kind of one of the triggers, probably. We're not sure exactly, like, why does the mom go into labor and say, okay, the baby's done, push it out. Like, what's the signal for that? Sometimes, a baby comes too early and the signals are wrong, and the baby's not born with the lipids. When the baby's usually born with surfactant, it comes out and it breathes and it cries, right? But a baby born too premature without the surfactant is going to need not just oxygen, because that doesn't really help open the airways, right? No matter how much you push or force air into that baby's lungs, you're not going to get those little teeny microscopic alveoli to open. So in the past, say 30, 40 years ago, a lot of babies died when they were born at 1 pound, 2 pounds, 3 pounds, and they died with newborn respiratory distress syndrome, NRDS it's called. And in the probably in the 30s, 40s, they just thought, well, we'll give oxygen to the babies, and they gave them a lot of oxygen, which actually was toxic, and a lot of children born in the 40s, 50s became blind because of the oxygen given to them because they were born premature. So luckily 30, 40 years ago, they discovered that the key to the surface tension problem and opening of the passages was due to surfactant, and of course they used to get it from pigs. I don't know if you know this, but a lot of stuff like insulin used to come from pigs until they could produce it in the laboratory, and surfactant was one of the things that also came from animals. And luckily, we now know how to make it using recombinant DNA and, E. coli and all that stuff in the laboratory. So babies born now get surfactant just kind of oozed down into their bronchi, and it goes down, and within minutes they can start breathing. So it's pretty awesome. Alright, so the anatomy review, you know this here, I just mentioned bronchi. So trachea on the left, the primary, secondary, tertiary bronchi or bronchus. Then you get the respiratory bronchioles, terminal, then respiratory here in the picture. Let's blow up here. Terminal. Respiratory has some alveoli, but most of them are in their own alveolar sacs. Okay? If you look from the top, we're taking a slice through here. We're getting a look at the heart in the front, the sternum, the spine in the back, spinal cord. I want you to see that the layers here. Okay, so around, remember the layer touching the organ, we said, if you don't remember, is it visceral or parietal? This is the visceral, here it says visceral pleura. So touching the lungs, there's a membrane called the visceral pleura. It goes up, it goes around, and comes back. The green part, can you tell the lines are different color, is the parietal pleura. We have the same for the heart. We have the parietal and the visceral pericardium. Peri means around. The heart, pleura means, guess, yeah, means lungs. And I want you to know that because there's a little space between the visceral and the parietal pleura, and I need you to know that for some of the pressures we're going to talk about. And that's called here the pleural cavity. Okay, so the pleural cavity is the space between the visceral and the parietal pleura. As you can see, it's not much space, right? Very little. And there's a little bit of fluid in there to keep these slippery, moving past each other. When any of this becomes inflamed, full of fluid, you can imagine it's painful to have a big, a cup of fluid stuck in here. Same happens on the heart. Pericarditis is called, inflammation of the pericardium. And then you get fluid on the heart, they call it, fluid on the heart. And that makes it really hard for the heart to fill when there's fluid in that pericardial cavity. Okay, so we get to talk about pressure again. So we talked about pressure when we did fluids and blood pressure, and also now you're familiar with mmHg. So this is a barometric pressure story. We're looking at this machine, which is not a machine, it's a tool. It's called a barometer. It's a piece of glass. One end is a vacuum at the top with mercury in it, and the other side is open to the pressure of the air sitting on top of it. And if you do this with a barometer, you'll see that the mercury gets pushed up on the side of here is just, ruler, up to 760 millimeters. Okay, so it's not very far. This is the number, 760 millimeters of mercury. So when we did 120 over 80, it would be right here, 120 over 80. I do have some old blood pressure cuffs that actually have the mercury, and students can see that, 120 over 80. But this is a lot higher, and this is the pressure of the air at sea level. So notice in the corner it says sea level, and that we're pretty close to sea level. We're at a height of about 50 feet here in San Jose. Okay, so this is a demonstration of a barometer used to measure atmospheric pressure. And you might have heard on the news, the barometer is dropping or rising, because it changes depending on, of course, the air pressure with weather. And a reminder, gases move from high to low pressure. You already know that. So the three pressures used for breathing are an atmospheric pressure. So around us, the pressure is 760 millimeters of mercury. The intrapulmonary pressure. Intra means inside. Pulmonary means lung. So inside the lung is the intrapulmonary pressure. It has a pressure, in this case, it's equal to the atmospheric pressure at 760. And then the inside the pleura, which is that little space there, intrapleural pressure is a little bit less. It's 756 millimeters of mercury. So you see I just kind of had to cut this out of another picture. Okay, atmospheric pressure, intrapulmonary pressure, and the intrapleural pressure. This is also a reminder of this major muscle here. What's it called? Diaphragm, right? So we're going to need our diaphragm in order to breathe. Okay, so the three pressures for breathing are atmospheric pressure, which we abbreviate as ATM, 760 millimeters of mercury. It's due to the weight of air. So let me ask you this. If you went to, I'm going to draw, how do I draw here? Let's see, pointer, felt tip pen. Here you are in San Jose, I don't draw very well. Okay, here you are in Tahoe. Okay, let's put you in San Jose. There you are. Yep. Here's your book. Okay, because you need to be studying. Here's your two eyeballs. Okay, then you go to Tahoe. Oh, and you have a bigger head, apparently. And you're going to go skiing. Whee! Okay, here you are skiing. There's your poles. Do not draw this. Okay, you are super happy. School is over. You need a hat. Okay. Where do you have more air on top of you? Here, let me draw this for you. San Jose. Here's the amount of air on top of you. Tahoe. Okay. Where do you have more air? San Jose or Tahoe? San Jose. Yeah. So there is less atmospheric pressure as you go up in altitude. That's just simply because of the height. Okay, the height of the mountain. So you're at 6,000 feet in Tahoe. You would have a decrease in atmospheric pressure. Okay, the intrapulmonary pressure in the alveoli. that number fluctuates. So when we breathe, that number goes somewhere around 760. It goes up and goes down and goes up and goes down, all around the atmospheric pressure, which the atmospheric pressure does change, but as you're breathing, it's staying the same unless, of course, you're driving up the hill. Okay? And if it's lower than 760, then air flows into the lungs. So think about that. If you have 760 outside, you have 750 inside your lungs, which way would the air go? It would come in, right? If you had 760 outside and 770 inside your lungs, then you would push the air out. So it always goes from high to low. We're like little vacuum cleaners, okay? High to low. So if it's higher than 760, air flows out of the lungs, and that's called an inhale, right? If it's lower than 760, and if it's higher, it's called an exhale. Okay, next we have my awful drawing here of this is the alveolus with 760, and the next pressure, which is the intrapleural pressure, is always 3 to 6 millimeters less than the atmospheric pressure. So I wrote here 757. Okay, in this, remember this space here, the sac going around is called the pleura. It's considered to be a negative pressure, but it's really not, right? The number is 757, which is a very positive number. It's a big number, but it's less than the atmospheric pressure. So the reason this is important is because the alveoli want to stay attached or stuck to the edge to the thoracic cavity. Okay, your rib cage, you know, your ribs are coming off over here on the sides. And this is going to want to stay because everything moves from high to low pressure, right? So this 760 wants to move towards 757, but it can't because there's a sac here to prevent it. But if we were to put a hole in the chest, let's say for some reason, maybe a bad accident or a wound or something like that, okay, so we're going to put a hole right through, then what's going to happen is the 757 won't stay like this, right? Because if you put a hole, then the air is going to come into the space, and how much is the air outside? What's the number outside? 760, yes. And when you do that, that's called a pneumothorax, where there's a hole in the pleura, and now you have 760 and 760, and what happens is a falling or a collapsing of the lung. Okay, so that is called a pneumothorax, and it's called a hole in the chest, and you'll get to try this on the PhysioX. The transmural pressure becomes 0 in this case. The transmural pressure gradient is what we call this. Trans means across, like a transatlantic flight would be to go across the Atlantic Ocean. And if a mural, let's say you go to Italy and you see a beautiful painting on a wall in one of the old churches, that's called a mural, right? So across the wall is transmural. Transmural pressure gradient is always this difference, like 760 to 757. Unless something crazy happens, like we put a hole, okay? And then the lung is going to collapse. I've had students tell me that I had a student once, a very thin student told me that she had a spontaneous pneumothorax. And I've had other students since then tell me they know people who have it too. Teenagers, it seems to be a teenage thing, and thin people, and I have no idea why that happens. If you have any more information, you can share it with our discussion group. Okay? So this is called the intrapleural pressure. So we had 3 pressures. We had the atmospheric pressure, the intrapulmonary pressure, and the intrapleural pressure. And this is what keeps the lungs attached to the side of the wall every time you inhale and exhale. Okay, let's see what's next. How do we breathe? Okay, now that you have all the pressures and you know the basics of it, I'm going to get my notes here so I don't have to see what's next. I'll have what's next in front of me. Okay, how do we breathe? So this is the picture I showed you earlier at rest. Let me see if I can put my pointer back to an arrow. Okay, so this person here is at rest. The atmospheric pressure is 760, and all these, it doesn't change. He's not driving. Okay, 760, and then the intrapulmonary pressure is 760, and the intrapleural pressure in this case is 756. Now, you want to take a breath in, so you have to take the diaphragm, you have to contract it, make it more flat, open up the rib cage with the intercostals. They have to pull so that the thoracic volume increases. Okay, so we're going to look at the external intercostals pulling. The volume goes up, the rib cage goes up, and remember, the lungs are going to go with it. And the reason the lungs go with it is because of this intrapleural pressure here, the transmural pressure gradient, right? So as the rib cage lifts, goes along with it. The inside changes a little bit to 754. That's the intrapleural pressure, because the lungs are following the rule to say if you increase volume, what happens to pressure? Think about this. If you have a balloon, the same balloon, and you, let's see, how do I want to think about this? If you increase volume, oh, I don't want to use the balloon. What's a good example of this? I always think of this of a jar that when I was a kid, we had a lot of Tupperware. That was the 70s, right? Lots of Tupperware, and we had this jar with a plastic lid on it. Okay, and if you increase the volume of the jar, it had a lid that went up and down. My mom put cookies in it. Okay, she put cookies in it when I was a kid. We made cookies. We didn't have a lot of money, so we made cookies. If we increase the volume, we actually decrease the pressure of the jar. Okay, so the lid would rise up so that the volume of air inside went up, and then you could, of course, fit more cookies, right? If she wanted to pack it in real tight so that it stayed fresh, that was the point of the Tupperware, she would push the lid down. And if you push the lid down, you could feel it even, right? When you push down the lid and you put more or less volume, you can put more pressure. Okay, so we have more pressure if we decrease the volume, and we have less pressure if we increase the volume. So if we increase the volume of the lungs in this case, what happens to this number, 760? It was 760, now it's 757. So we increase the volume, we decrease the pressure. The outside is still 760, right? So we have 760 outside now. Inside is 757. Which way will the air go? Out of the lungs or into the lungs? It's going to come into the lungs until it goes up really high, all the way full, and now you'll see the number has gone to 763. That 763 is now more than the atmospheric pressure. So as we exhale, we relax the diaphragm. The air now is getting pushed so that the volume goes down. If the volume goes down, the pressure goes up, and that pushes the 763 to outside, and that is where it's 760. Okay, so we go high to low, and we exhale. When we inhale, we go high on the outside to low on the inside, and we inhale. And then you're back to rest. Okay, so we just repeat this over and over again. The diaphragm, the intercostals change, the volumes change, the pressures change, and then the air just goes with the pressures. So here's the mechanics of breathing. Oh, this whole story about the Tupperware thing is really all about Boyle's law. So this says that pressure equals 1 divided by volume, or there's an inverse relationship between pressure and volume. So if you increase volume, you decrease the pressure. And the opposite is also true. If you decrease the volume, you increase the pressure. So let's go through the steps of an inspiration or inhale. So first thing we talked about was the diaphragm and external intercostals contract. And tell me again, as they contract, what happens to volume? What happens to the size of your chest when you inhale? The volume goes up. Yep, and the lungs expand. I'm going to find my clicker here. And what happens to pressure? If volume goes up, pressure goes down. Right, so the lung volume goes up, and there's a decrease in the intrapulmonary pressure to 757 millimeters of mercury. And which way will the air go? It will go high to low, which is what way? In or out? This is an inhale. So air will come in. So air flows passively from high to low pressure and comes into the lungs. And then you kind of hit a maximum, right, where everything kind of stops, because you stop the inhale, the exhale stops. Then you have to exhale, and to do that, we relax all of those muscles. It's a passive action. Did you know that? When you unless you're speaking like I'm doing. A normal inhale requires energy, but the exhale doesn't. Everything's just relaxing. The thoracic volume goes down, and what happens to the pressure when the volume goes down? When you push on that jar that I was talking about, push down to lower the volume, the pressure goes up. So the intrapulmonary pressure goes, say, to 763, and then the air flows passively from high to low pressure. Okay, so we saw a picture, which I didn't do a great job of explaining. It's hard for me. But, I love a steps thing, so this is good. And now I'm going to show you the animation. So you'll see it in 3 different ways, plus you'll read the book, and then you only have, see, that'll be 4 ways, and then you only have 3 more times to study it, and you're just going to get it. Okay, so let me show you the animation.
At the end of expiration, barometric air pressure and alveolar air pressure are equal. Therefore, no movement of air into or out of the lungs takes place. Inspiration begins with contraction of inspiratory muscles to increase thoracic volume. This results in expansion of the lungs and an increase in alveolar volume. The increased alveolar volume causes a decrease in alveolar pressure below barometric air pressure, and air flows into the lungs. At the end of inspiration, the thorax and alveoli stop expanding. Airflow into the lungs causes alveolar pressure to become equal to barometric air pressure. Because the pressures become equal, no more movement of air occurs. During expiration, the volume of the thorax decreases as the diaphragm relaxes and the thorax and lungs recoil. This results in a decrease in alveolar volume and an increase in alveolar pressure. Since the alveolar pressure is now greater than barometric air pressure, air flows out of the lungs. Air continues to flow out of the lungs until alveolar pressure becomes equal to barometric pressure.
Okay, next topic is resistance and airflow. So you already know this. Flow is equal to pressure divided by resistance. The same is true for air, as air is a fluid. Really, it acts as a fluid. So the resistance changes with airway radius, just like flow through the blood vessel. But in this case, the parasympathetic nervous system stimulates bronchoconstriction. Broncho, like bronchitis. Broncho means bronchus. Constriction, you know. And of course, what happens to airflow with bronchoconstriction? More or less? There's less. Sympathetic nervous system, epinephrine stimulate bronchodilation. What happens to airflow? It increases, right? And then there's a whole list of respiratory disorders that you're going to do in the PhysioX. There's a story with someone with asthma. How many of you have asthma? Several people know someone with asthma, right? When they get asthmatic, they start wheezing. They start making squeaking noise when they breathe. That's because those airways are blocked. Either they're constricted or usually they're full of mucus. And that's the body's way of, of inflammation, of trying to fix something with white blood cells. Okay, so that makes it hard for them to breathe. They take inhaler. They have an inhaler to open the passageways. Chronic bronchitis. Chronic means it doesn't go away. So this is typical of someone who has a smoker. They're coughing all the time. They always have inflammation. They're always coughing. Too bad. They should have never started smoking. Smoking is terrible, awful. Cystic fibrosis is a genetic disorder where someone produces a lot of mucus. They actually hypersecrete sodium. They secrete excess sodium. So if you did that, say, on your skin, where there is salt, water follows. So they might have really sweaty palms, sweaty body in general. The skin is moist, but the problem is other parts of the body also secrete more sodium. So the sodium in the lungs is secreted, and where there is salt, water follows. So then they have fluid in their lungs, and as you can imagine, you can't breathe very well with that. So there is no cure for cystic fibrosis. People are born with it, and the best they can do right now is a lung transplant, which of course is really hard to get, and the people have reactions, right, to organs that are donated to them. The last one, emphysema, also a smoker's problem. Not always, but mostly if someone has emphysema, you can assume they were a smoker if they're not now. They actually have broken alveoli. They don't have a lot of surface area then for movement of oxygen and carbon dioxide. Okay, so they have poor, they have a lot of resistance and poor airflow. Okay, let me give you a question for you to work on, and then you can pause the show and think about it. This is about Mr. Ellenheimer, a 68-year-old heavy smoker. Took the charter bus to Reno to gamble. This question was written by my class from back in the day, 1999. I used to work in Sacramento, and all the old people in Sacramento take the bus to Reno to gamble for the day. They just leave early in the morning, they go all day, and they hang out, and they come back. I don't think it's so common here in San Jose. It's quite a drive, and in Sacramento it's easy to get to. So, going over the Donner Pass, Highway 80 to Reno, Mr. Ellenheimer experiences slight difficulty breathing between coughing up phlegm. He ignores it because it has happened several times in the past, and he is happy playing cards with his girlfriends, Edna and Marge. Once Mr. Ellenheimer arrives at the casino, he's feeling better, so he races to his favorite machine. He lights up a cigarette and begins to have increased difficulty breathing. What external and internal factors could be affecting his breathing? Okay, so think about this, pause the show, and then we'll talk about it. Okay, so when he goes up into the mountains, right, we have external factor. So what's happening to the pressure of air as we go up in high altitude? More or less pressure? Less pressure, right? And remember that pressure, that number 760 on the outside, is a big role in the number on the inside. So if it's less as we go up in altitude, what has to happen to the volume that we breathe? What has to happen to how big our breaths are? Are they smaller or are they deeper breaths? Deeper, right? Deeper breaths, because we have to get that intrapulmonary pressure. It used to be 757, right? And outside was 760. Well, now we have to make a deeper breath so we can lower the pressure inside even more because the pressure outside has been lowered. So he has to take deeper breaths. We all do, not just Mr. Ellenheimer. If you go to Reno, you would have to also. But that's a problem for him, right? Because he's older, or old, let's just say. Okay, he's old. What happens to your flexibility as we get older? Decreases, right? So it decreases the flexibility even in our breathing and pulling those muscles on our chest. Okay, so he's older. He's got to breathe deeper just because he's at higher altitude. So that's an external factor. What does the smoking have to do with it? So he's got coughing up phlegm. So what is the phlegm doing to the airflow? It's decreasing the airflow, right? Why is it doing that? What's happening to the resistance in his bronchioles? Resistance has gone up, right? The resistance goes up, so the flow goes down. He can't get as much in because the inside is full of phlegm. Instead of being a nice clear passageway, he's got this mucus there. The mucus is because he's smoking, right? And the smoking causes irritation, and the body's trying to get rid of all the toxins and stuff like that. Okay? Let's see. Phlegm. He probably has chronic bronchitis, like we were just talking about. Anybody know about the, when you smoke, when a person smokes, what happens to the trachea? What happens to the cilia of the trachea? Do you remember this? They become paralyzed, and they no longer move the mucus up to your throat so that you can swallow the spit. Remember I told you it's okay to swallow the spit, okay? So the mucus from the trachea comes up. His is not doing that. So he's coughing it. Instead it's going down, so it's filling up the bronchus and the bronchioles. Of course, he's having a good time. I don't know. Increased difficulty breathing. Internal factors. I'm trying to think of anything else we missed. Emphysema. He might have had that. You can tell sometimes people with emphysema, they have like an oxygen tank with them to give them oxygen, because it's so much effort for them to inhale and exhale, so they walk around with these carts, you know. And I did have a student once whose grandmother had one of these tanks, and her grandma watched her children. Her grandma said she stopped smoking. I don't smoke anymore, I really don't. And she would babysit the kids, and then the kids would say, guess what? Grandma took off her oxygen tank and went and had a cigarette, then came back and put the oxygen tank back on. In case you don't know, oxygen tanks explode, and especially around a cigarette. So she's like, I have to find new daycare. I can't trust my grandma. I'm like, see, people just don't want to change. So I'm sure Mr. Ellenheimer not interested in changing his ways. He's having a good time with Edna and Marge. Okay, any questions? This is a spirogram made with a machine called a spirometer, and you can breathe in a spirometer and measure the lung volume in milliliters. This says cubic centimeters, which is the same thing as a milliliter. And when you breathe in and out, the maximum you can go is like 6,000 milliliters. The minimum is 0. A normal inhale-exhale that you have is called the tidal volume. Like the tide, it comes in, it comes out. I need you to memorize all of these terms and their values. Okay, so you start maybe 2,200 and you go up maybe to 2,700. So a tidal volume is about 500 milliliters. So remember the water bottle, I always use it. That is how much you breathe in and out with each breath. If you take a big exhale, as much as you can, all the way out, that's called the expiratory reserve volume. If you take a big inhale, anything beyond the tidal volume is called an inspiratory reserve volume. And take a look here, which one is bigger, the inspiratory reserve or the expiratory reserve? The inspiratory reserve is a lot bigger. This is because you are a human and you like to talk. Okay? If you look at your dog, you won't see this. The dog inspiratory reserve is like halfway, because if you have you heard your dog talk? Of course they don't talk, right? But they bark, right? Rah, 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 rah. Rah, 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 rah. They don't get very far, okay? I know, I'm doing it right now. Big breath in. I can just blab, 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 blab. Okay, so this is an inspiratory reserve plus the expiratory reserve and the tidal volume all make what you do in life, which is called the vital capacity. What's vita mean? It means life. So your vital capacity goes from the bottom here, say 1,200, to the top, say 6,000. You have, the other number you need to know is the residual volume. That's how much, once you took your first breath, when that surfactant was there and you took your first breath, your lungs will never collapse. Even when you die, those alveoli will still be open and you will still have 1,200 milliliters left in your lungs. Okay? That whole thing is called the total lung capacity. The amount that we use every day, or potentially, if we inhale and exhale the most that we can, which we probably don't, right, every day, the vital capacity is what that's called. So I need you to know all these except the inspiratory capacity, functional residual capacity. You might need to know this one for the Physio-X. I'm not sure. I don't remember. So you need to know these plus the ones in the Physio-X, okay? Fun fact. A cough releases an explosive charge of air that moves at speeds up to 60 miles per hour. A sneeze can exceed the speed of 100 miles per hour. And my kids, we always like to talk about this silly stuff at the dinner table. And we talk about how you can't keep your eyes open when you sneeze. So they think that's crazy and they always try to do it. And of course they can't. The last topic is ventilation. Ventilation is calculated as, remember that was breathing, right? Pulmonary ventilation is milliliters per minute. And the way you get it is by taking the tidal volume, which is how much you breathe in a breath. So remember, it's around 500. Those are the number of milliliters per minute, per breath, times your respiratory rate. So you breathe between 12 and 18 breaths per minute. 12 times a minute. You think that's a lot or little? What happens to your respiratory rate when you sleep? It goes down, yeah. And when you exercise, it goes up. Tidal volume, what do you think happens to your tidal volume when you exercise? It goes up a lot, right? And when you sleep, it goes down. So if your respiratory rate is 12 breaths per minute and your tidal volume is 500 milliliters per minute, then your ventilation is 6,000 milliliters per minute, or 6 liters per minute. That's easy. That's how much you have, right? You have 6 liters potentially, so that's about how much you would use in a minute. To increase ventilation, you would increase the tidal volume or increase the respiratory rate, but usually you do both. Okay, so when you run, you breathe faster and bigger breaths. A more accurate description of ventilation is alveolar ventilation. This considers that, remember when you breathe in, the air has to go through the bronchus, the trachea, the primary bronchi, the secondary. All that, remember, is called dead space. Do you remember that? That is space that does not have any alveoli, right? So the 150 milliliters of the 500 that you breathe in actually doesn't get exchanged. So we call that the dead space. And so technically, a better calculation is the alveolar ventilation, which says that tidal volume minus the dead space is used times the respiratory rate. So in this case, you would take 500 minus the 150, and you multiply it by 12, and you get 4.2 liters per minute of alveolar ventilation. This is less than the 6 that we had from the previous page, so it's probably a more accurate measurement. Okay, so I need you to be able to do both of these, to the pulmonary ventilation and the alveolar ventilation. Okay, we are done.